Assalamu alaikum. This is another case where we're looking at the x-rays for a patient with a possible bridge. We have, this is tooth number 5. We have this as what? Extraction. Extracted 6, and this should have been the 7. Slightly the roots of the 7 are fused in a way. So I'm a bit concerned about this because what does this do to the surface anatomy or surface area for the roots, for support, when you have the roots fused?
يعني بتأثر علينا على الشغل قصدي.
Yes. How the roots usually بالupper 6? Usually.
المفروض إنهم يكونوا
Separated. 3 roots.
one palatal
And 2 buccal, mesial and distal. Okay. For the buccal. What I have here is the fused. صح?
هذول اللي هم البقل.
Yes, these are fused and the palatal is present, but the ظلام yes. But this reduces the area. Okay, we're going to, we have the periodontal area around them. Okay, I could see some widening here. This could be attributed to occlusal trauma, overload. So this is the other side for the canine, just to include the canine, the periapical. I wish I could see the apex, but looking at the canine clinically, it's sound and we don't have any symptoms. We're okay with this. Now we're looking at this space. How are we going to replace this space? Are we going to do it a 5-unit bridge? What are the options? Well, it is an option. It is an option, but why do we not prefer this? Why? The premolar. What do we call the premolar in the middle of the bridge? With 2 saddles in front and back of it.
الفورس بتصير عليه عالية.
Yes, we have a lot of force and we have lateral forces even more. But what do we call it? This abutment, pier abutment. Do you know a pier's abutment?
Yes.
This is it. So 2 saddles, that means a lot of stress on this. But usually, which tooth in the arch is the weakest in terms of roots?
هو يمكن البريمولر.
The longest. The 4 is better usually. But this one has good roots, okay? Look, compare it with the canine, okay? So it has insufficient roots, okay? Even it might have 2 roots. I could see a shadow here, I could see a shadow here. They could be 2 roots. But we know because they run buccolingually, we need a tilt in the x-ray to see them. But the idea is the length of it is sufficient. This length of it, the palatal is excellent, okay? Looking at this palatal is excellent. So we are left with the option. Do we do it a 5-unit or 3-unit and we add a cantilever?
3 units.
Okay, so 2 abutments. Now with 1 and 2 pontics. So that now it's a cantilever, so it's a 4-unit with a cantilever. And this is, by the way, the best cantilevers, which is an anterior cantilever for 2 teeth posteriorly. Okay, so anterior cantilevers are the best.
لأنه كل الفورس حتكون على البوستيريور، ما راح يكون عندنا كثير.
Exactly, we have enough roots usually with the more posterior teeth, especially in the 4. We're replacing the 4 by cantilever. Okay, we don't have an angle of the mouth. So the fremitus and the actual movements are around correctly. So that means this is most favorable. Now, one concern I'm left with to talk about in this evaluation of X-ray for bridge work. These are 50-year students evaluating patients for conventional bridge work. Let's talk a little bit about caries, but I'm going to detail it in another video. We have a little caries. This is enamel caries, صح? How do you know that's enamel caries?
إنه بس يعني مو داخل على دنتين.
How do you know it's not into dentin? But we know usually cavities on X-rays are usually a lot smaller than they are actually. So how do I know it's not into dentin?
إنه clinically إذا في catch.
Okay, excellent. The catch here I could count it because this is smooth enamel. So any catch is an actual cavitation. But what else? And this is a benefit. This is a benefit for having an isolated tooth. I could see it directly. So this is direct vision. Nothing complicated about it. So if I have a catch, this is into dentin. But usually when we have the V shape in enamel, when we definitely consider it into dentin when the V shape is touching the cemento-enamel junction. Dento-enamel junction. Okay? So if it's not touching this junction, we're not sure. Okay? But here you have the benefit of the doubt. You have the actual direct vision. So you don't need to doubt about it. So go and probe it. And enamel caries, is this manageable with the crown bridge work?
Yes.
Why? Yes, because we're preparing enamel anyways. So any enamel lesions are okay. Okay, so deeper enamel lesions, I'm going to discuss them in another video. Okay, here I have something. What could these be?
maybe cervical burnout.
Okay, cervical burnout is an option here because we have enamel meeting dentine and cementum, and usually sometimes we don't. Not all the enamel meets cementum.
حتى كلينيكال راح يكون باين معنا اذا
clinically we can see it. Oh, okay. Suppose it was a bit root caries. Can I manage it with my crown bridge work? If it was.
على preparation.
Yeah, you can do subgingival here. It's not too much into subgingival. This could be included in the margin if it was. But as I told you, once more you have the benefit. Now the final thing that I'm doing this video all about, just this was the primary intention of this video, is what do you see here? Recession, a lot of bone recession.
Yeah.
Okay, so this tooth with the two roots and the long palatal, I don't think it will be the mobility that's the problem. There's something else as a problem. What is it? Do you see the soft tissue reaction?
Yes, yes.
Okay, it's large. The soft tissue is not following the recession. Okay, look here. The soft tissue and the bone are close, while here they are a lot. So if this was a periodontal involvement, definitely it is involved. I mean, it has been previously involved. One issue is the cleansability of this tooth. Now, you haven't done scaling nor root planing yet. Okay, so after you do the debridement, I want to see the pocket's depth afterwards. Okay, what we should see if you have done correct debridement of the roots, you're going to see two things, or let's say palpate two things. While you're doing the planing, you're looking for bifurcations because those are difficult to clean unless you're going to use a water jet. Okay. Secondly, I would like to see this patient before your final preparation after the root debridement. Why? Because if there was some edema here, it will reduce. Okay, it will recess any edema in the soft tissue. So any soft tissue reaction, if it's reversible and we remove the active inflammation, this will come down. So coming down, that means it will expose my margin. And favorably, we need supragingival margins, but not too much away from the gingival. So I would prefer to have this tooth prepared after 1 to 2 months after it has been stabilized, after perio. Yes. Definitely do sensitivity test because if you have sensitivity test that obliges you to go to root preparation. Check mobility. I don't think there is a mobility, but recheck it. Check vitality. You don't know. You might have a tooth not vital for any reason. But usually in these conditions, usually teeth are vital, unless there is a problem, a trauma or a big hit to it or something like that. Some widening in the canal. So the periostatus. Now, if this is cleansable, say we have the bifurcation, you know it like it comes like a constriction like this. Like the roots are constricted inwards. Okay. If you have that, if the patient is not going to use water jet, these are not cleansable usually. Okay. If the tooth has sensitivity, we need to go to the root preparation. So many issues around this periodontal status of this tooth. So this is why. Also, it reduces the support for the cantilever. So if the patient is going to do this as a bridge, it will be with guarded prognosis, we say. If the patient insisted on doing a bridge and not moving to a removable, this is what we call guarded prognosis. Guarded meaning that I need to keep an eye on it. I have to recall patients regularly every 6 months, keep an eye on it, probe it regularly, check the oral hygiene, plaque indices around it, gingival indices as well. Okay?